Bismillah, disclosures. I am an interventional cardiologist who have been learning and practicing cardiac multimodality imaging for the sake of better understanding of the morphological variants of the different cardiac lesions to achieve the best possible management plan. Introduction. RVOT anatomically is defined as the tube-like portion of the RV cavity above the supraventricular crest and defined superiorly by the pulmonary valve. In our practice, we use the term RVOT more generally to include the main pulmonary artery, especially in post-operative cases with no well-defined pulmonary valve. The recent advances in surgical and percutaneous intervention demanded a more thorough and detailed assessment of the anatomical and functional characteristics of the RVOT and its surroundings. Multimodality imaging of the RVOT became the best choice for assessment instead of using a single imaging tool to cover all required information for further management. In our talk today, we will cover the different imaging modalities and different assessment points of RVOT in the light of the recent intervention techniques. First, assessment of the obstructive lesions. Aim of assessment, level of obstruction, whether it is subvalvular, valvular, supravalvular, or peripheral. Mode of obstruction, whether it is dynamic or static, focal or diffuse. And of course, whether there is no forward flow at all in cases with pulmonary atresia, membranous type with imperforate pulmonary valve or atretic main pulmonary artery. The degree of obstruction, mild, moderate, severe, by the pressure gradient across the RVOT by the Bernoulli equation simply. However, in cases with suspected peripheral pulmonary stenosis, we should also consider the RVSP because for fear of malalignment of the cursor with the direction of the flow across the LPA or RPA. So you don't depend only on the pressure gradient you detect by continuous wave Doppler. You should also consider the RVSP in case you are sure that there is no more proximal obstruction. In management, medical, percutaneous, or surgical, in case of you are recommending percutaneous management as balloon dilatation of valvular PS, you should comment on annular diameter, or for cases of peripheral PS, whether balloon or stenting, you should comment on the diameters of the arteries. And don't forget other lesions that may affect the management plan, like shunts that will increase the pulmonary flow and may overestimate the pressure gradient across the RVOT, or in cases with peripheral pulmonary stenosis and severe pulmonary regurgitation, you should lower the threshold for intervention for peripheral PS because it will increase the hemodynamic effect of pulmonary regurgitation on the RV. The choice of the imaging modality, the first and basic imaging modality is echo. It will give you anatomical and functional assessment and should be adequate in valvular, supravalvular, and subvalvular stenosis. However, if you are suspecting peripheral PS, you should resort to a more advanced imaging tool. The multi-slice CT is the one of choice. It will give you only anatomical, however, with higher resolution, especially in post-stenting. Like in this case, you can see the fracture in the stent. The cardiac MRI will give you anatomical and functional information. However, it is not very accurate in obstructive lesions, but it is the gold standard for RV assessment, volumes and function, and it is the only tool that you will detect fibrosis because of its tissue characterization capabilities. طبعا احنا هنا شايفين subvalvular في subvalvular obstruction في العينة ديت، ودي peripheral PS. Pulmonary regurgitation, the aim of assessment, the degree, the etiology, and the management, and we'll discuss each and every one of them. The degree of pulmonary regurgitation, the echo gives you a qualitative assessment of the degree of pulmonary regurgitation by diastolic flow reversal, which is the main used tool in our practice. However, there are other quantitative measurements proposed only still under research for their accuracy in the assessment of our pulmonary regurgitation. The gold standard for quantitative assessment of pulmonary regurgitation fraction is the cardiac magnetic resonance. The now available tool is a 2D based cut section of the pulmonary artery and tracing of the pulmonary flow, and it will give you the pulmonary regurgitation flow. However, the newly proposed 4D cardiac magnetic resonance should give us a more accurate assessment of the pulmonary regurgitation, especially in cases with markedly dilated pulmonary artery and turbulent flow. Second point to assess by the pulmonary regurgitation, the etiology. Whether it is iatrogenic in cases with the transannular patch, or a non-valved conduit, or post-balloon pulmonary with malcoapting pulmonary leaflets, or degenerative of a native pulmonary valve, like this case. You can see this is an on-fuzz view of the valve. The valve is, the whole leaflets are fused and thickened tips, causing severe stenosis and regurgitation at the same time. Or post-surgical degeneration of a valved conduit, RV to pulmonary artery conduit, or this case with a post-pulmonary valve replacement and degeneration of the leaflets of the valve. The management. Pulmonary valve replacement is indicated in cases with severe pulmonary regurgitation with presence of one or more of whether progressive RV systolic dysfunction, dilated RV volumes, RVSP more than 80 millimeters mercury. So when you decide for pulmonary valve replacement, whether it is percutaneous or surgical, the assessment of the landing zone will be the point that you will decide upon. Commercially available valves for cath replacement are with the largest diameter of 36 millimeters. So largest acceptable pulmonary artery transverse diameter is 34 millimeters, and the shortest acceptable length of the landing zone is 25 millimeters. So beyond these measurements, the surgical replacement is the suitable option. Other relative contraindications for transcatheter pulmonary valve replacement are body weight below 25 kilograms, coronary artery origin or course less than 2 millimeters distance from the landing zone, or untreated peripheral PS. The assessment of landing zone, meaning that you will measure the length of the landing zone, which is the distance between the pulmonary valve annulus and the origin of the first branch, and the cut section diameter at these four landmarks: the distal RVOT, the annulus, the main pulmonary, and pre-bifurcation. The cut section, you will measure the major diameter and minor diameter, and don't forget the distance of the coronary artery from the main pulmonary artery. This is a 3D cardiac MRI in these images, not CT. In cases of native RVOT, you should also consider the RV pulsatility, which is the difference in cross-sectional area of the RVOT during cardiac cycle, meaning the difference in the diameters during systole and diastole, because as you can see in systole, the diameters are larger, and also the length of the landing zone will differ from systole and diastole. The other point is eccentricity, the difference in minor versus major axis diameter of the RVOT, because these two parameters, if they are very high, this is a very unfavorable anatomy for percutaneous pulmonary valve replacement. These measurements in CT, and this is cardiac MRI. Cardiac MRI gives you an additional advantage because you have a cine image, so you can decide which is the largest diameter. You can see the artery while it is contracting and dilating, and you can see by your eye, you define the largest diameter. This is the most accurate هو largest diameter علشان ما نحطش حاجة يحصل لها embolization. So as an example for this case, this is a landing zone, very short, 24 millimeters, and the cross-sectional diameters are 38 millimeters by 27, which is, this is a large difference between both diameters, and also 38, we said before that the largest available valve is 36, so you need to, the largest diameter to be 34. So by these measurements, this is not a favorable anatomy for percutaneous pulmonary valve replacement. However, this patient had a very interesting finding. Where is the left pulmonary artery? This patient had a congenitally absent left pulmonary artery. So the main pulmonary artery continues as the right pulmonary artery. And the right pulmonary artery actually had a stenotic origin. And then distally it measures 18 millimeters in diameter. So it gives us a very suitable alternative landing zone for melody valve, which is according to these diameters, it's the more suitable valve for such diameters. So we did pre-stenting. Melody valve always needs pre-stenting of the right pulmonary artery, and the valve was put beautifully inside the right pulmonary artery, and you can see there is no regurgitation. And this is the cardiac MRI follow-up after 1 year of the implantation of the valve. And this is the cross-section. We can see the well-coaptation of the struts of the stent to the right pulmonary artery. In cases with RV to pulmonary artery conduit, the assessment of the landing zone would be much easier because there is no pulsatility and no difference in measurements during systole or diastole. So in this case, we can see that the length of the conduit is 44, which is a very long distance, and the diameter of the transverse, the cross section is 16 millimeters. This is the conduit put for this patient as a child. Now she is an adult. So, and we can see that there is a distal stenosis and proximal stenosis at the proximal and distal insertion points of this conduit. And this is the coronary distance also. So if you want to put or try to put a percutaneous pulmonary valve, in this case, you should start to dilate the conduit first, and then you make pre-stenting. But because we have a very long distance and two proximal and distal stenosis, we had to use two overlapping stents, and then the valve was put inside of them. After all these modifications of the anatomy to make it suitable for percutaneous pulmonary valve replacement, if the landing zone was still not suitable for pulmonary valve replacement, you will send the patient for surgical pulmonary valve replacement. You should comment on the distance of the RVOT to the sternum, because in cases with markedly dilated RVOT, like this patient, the dilated RVOT will be resting on the sternum, so there is a very high risk of injury to the RVOT while the median sternotomy. The other thing you should comment on, if there is any need for reconstruction, like cases with RVOT aneurysms like this one, or multiple aneurysms like this patient. Last, this is a very important point. If any patient will need an RVOT intervention and he has a documented non-sustained or sustained ventricular tachycardia, you should assess the presence of fibrosis, and he should be ablated before an intervention, because you will induce tachycardia. Take-home message: recent advances in intervention increased the demand for more detailed assessment of the RVOT as well as all other cardiac structural lesions. Multimodality imaging with using of the advantages and compensating for the limitations of every single imaging modality in a complementary fashion is the best way for accurate assessment for better decision making. It's crucial to know the aim of any imaging study to answer the questions needed to decide the best management plan for every individual case. It's crucial to know the superiority and limitations of every imaging modality to decide which is the best tool for every requested information. Thank you.
Sorry. Okay. This is my agenda: disclosure and definition, types, and management, and my take-home message. It's well known that the congenital heart في مشكلة مش صح؟ طب استخدم مين فيهم؟ عشان يجي استخدم مين؟ ما هو مش هنا مش شغال وهنا بعدين يجي ورا بعض كده بص اوكي سوري
اعتقد ان في مشكله بس في الكيبورد.
طيب اوكي
في عند حضرتك كليكر ممكن تستخدمي W في السلايد اللي بعدها.
خلاص يعني هو
ده بيرجع اللي قبلها ده اللي حضرتك عايزه تغيريه.
طيب اوكي خلينا هنا.
هو اشوف المشكله طيب بعد ما
مفيش مشكله. It's well known that congenital heart disease is a lifelong chronic condition from just birth up to the death, and it needs critical care for all patients. So understanding the atrial septum is crucial for all specialists, especially those interested with congenital heart disease. Atrial septal defects account for the second most common congenital malformation. Worldwide prevalence increases. It's 1.65 per 1,000 persons, and it increases because of the widespread use of echocardiography in clinical practice. By definition, atrial septal defect is a direct, persistent communication between the atrial cavities that allows shunting of the blood. Okay. Any hole which permits shunting of the blood between both atria, especially those greater than 3 to 4 millimeter in size, is called atrial septal defect. It should be distinct from the patent foramen ovale, where there is a flap in the intermittent communication. It's not a communication all the time. These holes can occur in isolation or in association with other defects in complex congenital heart disease. These are the types of the atrial septal defects where secondum, venosus, primum. Okay. There are variants of interatrial communications that are located outside the area of the true atrial septum. The types are ostium secundum, 75% of cases, ostium primum, which is up to 20% of cases, or sinus venosus, which up to 10% of cases, and very rare conditions regarding coronary sinus. Let's start with the patent foramen ovale. This is configuration of normal septum. It has an oval fossa that's sufficiently large to overlap the rim of the fossa. Approximately 25 to 34% of the population, there is incomplete adhesion between the flap valve and the fossa rim leaves a service at the anterosuperior quadrant of the rim that opens in the fetal ostium, as you can see here, where we can pass a probe from the right atrium to the left atrium. And this is the patent foramen ovale. Okay, there's considerable confusion regarding the use of the name PFO or whatever. Sometimes it's used to describe any central small interatrial communication less than 4 millimeters. Sometimes it's incorrectly used to describe an interatrial complication at the site of the oval fossa valve, or so-called secundum ASD, where the valve is inadequate to overlap the rim so that the FO is not obliterated. Size varies from 1 to 10 millimeters in diameter. The length of the tunnel varies, of course, and it has two types, valve competent and non-competent. Some cases have aneurysmal valves which can bow in either atria during respiration, as we can see here. The second type is secundum defects. The secundum defects are holes in the true atrial septum. They are located in the flap valve covering the oval fossa, the septum primum. They vary in size from small perforations to complete absence of the valve guarding this oval fossa. But as we know that defects more than 10 millimeters or that are occupying 1/3 of the length of the interatrial septum, or those with QPQS more than 1.5 should be closed. Spontaneous closure can sometimes occur in small defects, first two of life, and conversely, defects can also enlarge with somatic growth in the late childhood and adolescence. The primum defects. These defects represent persistence of the embryonic ostium primum. It permits interatrial shunting outside the true atrial septum. In many cases, the oval fossa is well formed and attacked. The hole lies between the free margin of the atrial septum and the atrial surface of the conjoined leaflets. Here we come to the atrioventricular valve and the atrioventricular septal defects. These defects are better considered with atrioventricular septal defects or common atrioventricular junction. Okay, it's very important to say that the AV node in these hearts are abnormally located, which is very important. The other type is sinus venosus defects, whether superior or inferior defects. The superior is commoner than the inferior ones, and the superior sinus venosus defects allows the orifice of the caval vein to override the septum and drain into both atrial chambers. It has a well-defined inferior border with no proper superior border. Usually it's associated with partial anomalous connection of the right superior pulmonary vein into to the superior vena cava vein. Surgical closure of this defects with a patch should take care to avoid obstruction of the pulmonary venous return to this left atrium. The inferior type is the same, far less common than the superior type, and it has, again, right inferior pulmonary vein may be connected anomalously to this inferior vena cava. The coronary sinus defect. They are holes at the site of the coronary sinus orifice that allows direct interatrial communication or are located in the posterior inferior wall of the left atrium, allowing passage of the blood between the left atrium and the coronary sinus channel. They were known before this unroofing of the coronary sinus, and anatomically speaking, they are holes due to deficiency in both the coronary sinus wall and the inferior wall of the left atrium. Holes in this location can be large, small, wherever, single, multiple, they are varying. They are associated with persistent patency of the left superior vena cava. There is a direct venous drainage into the left atrium. What about the clinical manifestation? These are the types and different anatomical types. What about the clinical manifestations? Sometimes they are symptomatic until the first decade of life. The clinical course is very variable. Very small ASDs, less than 5 millimeters, may not have significant clinical consequences. Others from 5 to 10 millimeters may lead to symptoms in 4th or 5th decade of life. Larger defects more than 10 millimeters typically presents earlier in life, and aging is, of course, associated with increased left ventricular stiffness and impairments in the diastolic filling, leading to an increase in left to right shunting across this ASD and right ventricular volume overload. The symptoms vary from dyspnea, fatigue, exercise intolerance, stroke, maybe syncope, maybe recurrent pulmonary infections, maybe it's very uncommon orthodoxia, aplatepnia syndrome, or maybe arrhythmias, a lot of symptoms and signs. Sick sinus syndrome, stroke, whatever. Eisenmenger syndrome is the sequelae without treatment of the interatrial shunt defects. Okay. How can we diagnose ECG, right axis deviation, right bundle, even superior left axis, complete heart block sometimes. How to diagnose? The key is the echocardiography to visualize the defect, direction of the flow, any other anomalies. These are some defects, as we can see here. Okay. Again, 3D. TE and 3D transthoracic echo are crucial in the diagnosis of these cases. What about the management? It's medical, surgical, percutaneous closure, or even symptomatic in Eisenmenger syndrome. The guidelines say, let's see this one. If we have RV volume overload, yes, if we don't have RV volume overload, just look at if there is a paradoxical embolism. If yes, just go for closure with class 2A indications. If no, no closure. But if we have RV volume overload, look at this. Check for the LV disease. If there is no LV disease, check for the pulmonary vascular resistance. If it's less than 5 and QPQ is 1.5, then go for closure of the ASD. If not, if you have an LV disease, no LV disease, then go for closure. This is class 1 indication. If yes, check for the balloon testing. Okay. The contraindication for closure of these defects is the presence of pulmonary vascular resistance more than 5, and which is not even reversible using the techniques for pulmonary hypertension. This is my last take-home message. ASDs are common congenital abnormalities that most commonly occur as an osteum-secundum defect. Left to right chanting generally leads to right ventricular overload and symptoms in adulthood. Echocardiography is central to diagnosis and also informs the interventional approach. Percutaneous or surgical closure may be indicated in the presence of RV volume overload, paradoxical embolism, or orthodoxia platypnea syndrome. Thank you very much.
تمام. هو التايم very short 10 minutes، فنحاول يعني نبقى go rapidly through the lecture. ايه الديفينيشن بتاع السنجل ventricle؟ في multiple definition but the simplest one is it is a cardiac malformation in which both atria connected to only one ventricle either by two separate AV valve بنسميها double inlet or common AV valve بنسميها common inlet. Functionally, there is only a single ventricular chamber that support both pulmonary and systemic circulation. في many nomenclature بتاعت السنجل ventricle either univentricular heart, double inlet ventricle, univentricular atrioventricular connection, common ventricle or functionally single ventricle. الموست كومن او اللي دايما بيقولوا عليه هو السنجل ventricle هو الهارتس with double inlet AV connection، هو الدبل inlet left ventricle or double inlet right ventricle. Other congenital malformation also categorized as univentricular heart depending on the hemodynamics and the surgical management. Hearts with absence of one AV valve as tricuspid or mitral atresia, hearts with common AV valve as the unbalanced complete AV canal, heterotaxia syndrome with one functioning ventricle, hypoplastic left heart or hypoplastic right heart, or severe forms of double outlet right ventricle. طبعا ده المالتي congenital abnormalities double ended left ventricle, tricuspid atresia, unbalanced AVSD, hypoplastic right heart, this is pulmonary atresia intact septum, hypoplastic left heart, and double outlet right ventricle. بنركز على الباثولوجيك اناتومي as regard the ventricular morphology, atrioventricular connection, ventriculo-arterial connection, and the interventricular communications. Starting with the commonest type with the double inlet left ventricle with hypoplastic right ventricle is the most common form, and the rudimentary RV is located anteriorly, and the dominant ventricle is defined as left ventricle is if one or both AV valve are in continuity with the semilunar valves. The commonest type is the double inlet left ventricle with LTGA, where the rudimentary chamber is located anterior and to the left, and the aorta arises from this rudimentary chamber. It is LTGA. The second common type is the double inlet left ventricle with DTGA. The rudimentary chamber is located to the right where the aorta arises, and the rarest type is normal great arteries, which is called Holmes heart, with normally related great arteries. Double inlet right ventricle extremely rare, and we can differentiate between both types of double inlet ventricle if the dominant ventricle is of left ventricular morphology. The relation of the rudimentary chamber is usually anterior, either to the left or to the right, and the orientation of the trabecular septum is anterior, while the AV valves are posterior to the trabecular septum. If it is of right ventricular morphology, the rudimentary chamber is posterior and the trabecular septum also posterior, while the AV valves are anterior. If it is undifferentiated morphology, there is no rudimentary chamber and no trabecular septum. According to the atrioventricular connections, there is a double inlet AV connection, and it is usually associated with left ventricular morphology. Common inlet single ventricle usually associated with right ventricular morphology, and single inlet in tricuspid or mitral atresia. The ventricular arterial connection, either concordant, discordant, double outlet from the dominant ventricle or from the rudimentary chamber, or single outlet heart. Interventricular communication, either ventricular septal defect, which is usually muscular type in double inlet left ventricle, or bulboventricular foramen, and it can be unrestrictive or become restrictive later on with time, or after pulmonary artery bending, usually become restrictive after that. The list for echocardiographic evaluation in single ventricle, we must focus on the morphology of the single ventricle. It is left to right or undifferentiated morphology, the location of the rudimentary chamber, the AV connection, double inlet, common inlet, single inlet, the AV valve morphology, either stenosis, regurg, hypoplastic, straddling, overriding, the ratio of the mitral and tricuspid valve, DTGA or LTGA, pulmonary hypertension or stenosis of the pulmonary valve or aortic valve, the size and anatomy of the pulmonary arteries, the ASD size, whether there is good mixing or restrictive shunt, the VSD or pulboventricular foramen, and obstruction of the foramen is considered if the velocity or the gradient is more than 1.5 meter per second, or the area of the foramen is less than 2 centimeter square. LV function, either the ejection fraction or the end diastolic pressure, and the associated defect as coarctation interrupted arch or PDA. This is the diagram for the evaluation of the single ventricle. Here some videos for types of single ventricle. This is double inlet left ventricle of LTGA. Here the pulmonary artery arises from the dominant chamber and across the bulboventricular foramen, the flow go to supply the aorta. Here the aorta is to the left, arise from the rudimentary chamber. As regard tricuspid atresia as a type of single ventricle, here the tricuspid valve is atretic and rudimentary RV chamber, and the source of the pulmonary of the aortic flow is through the bulboventricular foramen. Across the muscular VSD here. This is the hypoplastic left heart. And this is mitral atresia, and this is mitral hypoplasia, and the apex is formed by the right ventricle, while the left ventricle is hypoplastic. Here, the enlarged pulmonary artery due to excess pulmonary blood flow and the hypoplastic aorta and maybe aortic valve atresia. And this is the unbalanced form of the AVSD. There is preferential flow to the right ventricle. As regards the hemodynamics of the univentricular heart, we all know that there is normally two chambers supplied, the systemic circulation and the pulmonary circulation in series. But here there is single chamber supplied, the systemic and the pulmonary circulation in parallel. And the systemic oxygen saturation or the normal saturation is according to the pulmonary blood flow and according to the size of the bulboventricular foramen. So maybe inadequate pulmonary circulation, and this is in severely stenotic pulmonary valve or induct dependent circulation. Excessive pulmonary circulation with systemic obstruction or without systemic obstruction according to the size of the bulboventricular foramen or VSD, or balanced pulmonary flow. According to the hemodynamics and the anatomical morphology, we can go to the surgical approach to the single ventricle. If we have no pulmonary stenosis and unobstructed pulmonary bulboventricular foramen, there is excess pulmonary blood flow and the baby may be presented with congestive heart failure. So we can do pulmonary artery banding early to prevent the early development of increased pulmonary vascular resistance. If there is no pulmonary stenosis with obstructed bulboventricular foramen, we can do the Dembski stencil operation. Here we can divide the pulmonary artery and it is connected to the ascending aorta, and we can do here the PT shunt as a source of pulmonary blood flow. Pulmonary stenosis with unobstructed bulboventricular foramen, in critical pulmonary stenosis or pulmonary atresia, we can do the PT shunt or PDA stent. If there is obstructed bulboventricular foramen in association with pulmonary stenosis, here there is systemic and pulmonary obstruction, we can enlarge the bulboventricular foramen and put PT shunt. This is the first stage. At the age of 3 to 6 months, we can do the second stage, which is bidirectional Glenn or hemifontaine, and later on we can do the fontaine at the age of 4 years. Echocardiography is diagnostic, and also we can reach for the diagnosis before surgery by cardiac catheterization, because for the prerequisites of the Glenn, the mean pulmonary artery pressure must be below 15, pulmonary vascular resistance below 4 Woods unit per meter square, and the pulmonary artery are favorable in anatomy, and the Magoon ratio must be above 1.5. And there is prerequisites also for fontaine operations, the minimum age above 4 years, sinus rhythm, normal caval drainage, the right atrium must be of adequate volume, the mean pulmonary artery pressure not exceed 15 millimeter mercury, pulmonary resistance below 4 Woods unit, and the pulmonary artery to aorta diameter above 0.75, and normal ventricular function as regards the ejection fraction and the end diastolic pressure, competent AV valve, and if it is incompetent must be repaired before the operation. And the prerequisites Fontaine case, the anatomy of the pulmonary artery and the pressure, the resistance, RV2 pulmonary artery gradient, venous return, diastolic pressure, the presence of functioning previous shunt not affecting the anatomy or the hemodynamics. And this is the Fontaine detected by the echo, and this is the fenestration that can be detected in the atrium, and this is the flow in the Fontaine, and this can be obstructed or stenotic opening with pressure gradient above 7 millimeter mercury, and this is the Fontaine that can be detected during cardiac case. It can be intracardiac with fenestration or extracardiac, and the extracardiac is preferable because it avoids the late atrial arrhythmia. And thank you.